Welcome to the deep dive. This is where we take your information, the sources you provide, and really boil it down to the essential knowledge you need. Think of it as your personalized briefing.
Exactly. A way to get up to speed quickly and effectively.
Today, we're diving into something pretty important in clinical practice, challenging skin conditions.
That's right. We're working from a chapter you sent over, Skin Challenging Conditions, from Wound Care Essentials, Practice Principles. It's quite a detailed look at a range of issues.
And it really covers a lot of ground, doesn't it? We've got contact dermatitis, both allergic and irritant types.
And then moisture-associated skin damage, MASD, which includes things like IAD, incontinence-associated dermatitis, and ITD, intertriginous dermatitis.
Plus skin tears, psoriasis, epidermolysis, bullosa.
Wow. And it even touches on some, well, more complex and maybe controversial ideas like skin failure and skin changes at the end of life.
It does. So our goal today is really to navigate all this information, pull out the key takeaways, and focus on what's most relevant for, general clinical understanding. Okay, sounds like a plan. Let's jump in. First up, contact dermatitis. It's something many of us encounter. What's the fundamental split we need to understand here?
Right. The absolute crucial thing is knowing the difference in how the skin is reacting. So with contact allergic dermatitis, it's your immune system learning to react. Your skin has to meet the allergen once to get sensitized.
Ah, okay, like developing the allergy.
Exactly. Then the next time it sees that allergen, boom, you get that red, itchy reaction. But contact irritant dermatitis is different. It's direct damage.
Direct damage.
Yeah, physical or chemical injury straight to the skin. It can happen the very first time you touch something irritating, especially if it's strong. No prior sensitization needed.
Got it. So when you're looking at a patient's rash, what visual clues might point towards allergy versus just irritation?
Well, allergic reactions often look quite bright red, typically very itchy. And interestingly, the rash pattern often perfectly matches where the allergen made contact.
Like the shape of a watch strap or something.
Precisely. And it's worth noting, you often see this associated with venous leg ulcers, probably because of all the different creams and dressings used over time.
Right. And if you do suspect an allergy, how do you actually confirm what the culprit is? I think I read about patch testing.
Yes, patch testing.
Yeah.
That's the key diagnostic tool here. It's like detective work for the skin.
How does it work exactly?
So we apply a standard set, often the North American series, which has about 50 common allergens onto the patient's back using small patches. These stay on for 48 hours.
Okay.
Then we take them off, do an initial read, and then a really crucial final read at 96 hours.
96 hours? Why wait so long?
Ah, good question. That wait time lets any simple irritation from the tape itself calm down.
Yeah.
What you're left with are the true allergic reactions. That's a type 4 lymphocytic response, a delayed immune reaction.
I see.
And a practical tip. If you suspect a wound product, you can test it directly on a patch of the patient's normal skin for 48 hours too. Sometimes the trigger isn't in that standard panel.
That makes sense, sort of a direct challenge test. So who are the usual suspects? What allergens often show up positive in these tests?
Well, there are definitely common offenders. Topical antibiotics, things like bacitracin or neomycin, frequent culprits.
Right.
Preservatives, too, like propylene glycol or quaternium-15. Fragrances, balsam of Peru is a classic one. And even stuff in dressings like colophony or carboxymethylcellulose and hydrocolloids. And perhaps surprisingly, even some topical steroids themselves can cause allergic reactions.
Wow. Okay. So if someone is having an allergic reaction, what are the classic symptoms and how do we usually treat it?
You'll typically see that bright redness erythema, often with little fluid-filled bumps, vesicles, or sometimes bigger blisters, bulli. Intense itching, pruritus is almost always there, maybe some burning too.
And treatment?
Usually topical steroids are the first step to calm down that inflammation. Sometimes we might use topical calcineurin inhibitors like tacrolimus or pimecrolimus. They're immunosuppressants, basically. They can be good alternatives, especially for sensitive areas or longer-term use. For really bad or widespread reactions, oral antihistamines help with the itch, and sometimes a short course of oral steroids is needed to get things under control.
Right. Now let's flip back to irritant dermatitis. We said this is more common, not an allergy. What's actually damaging the skin here?
It's direct chemical or physical assault on the skin's outer layer. Think strong stuff like acids or alkalis, harsh soaps, detergents, maybe even wet cement.
Ouch.
Fabrics, softeners, solvents, lots of chemicals. Stronger irritants cause a reaction faster. Weaker ones might need repeated exposure. And don't forget simple friction that can be a major irritant too.
And what does irritant dermatitis look like? Is it easy to tell apart from an allergic reaction just by looking?
Well, it also presents as a red, itchy rash, so visually it can sometimes be tricky.
Yeah.
But the key is remembering it's not an allergy, it's not contagious. It's just the skin saying ouch to whatever's bothering it.
Okay. Now, this seems really relevant for wound care. You mentioned irritant dermatitis often shows up in specific patterns related to moisture or products we use.
Absolutely. A lot of the skin issues we deal with fall under this irritant dermatitis umbrella. Moisture-associated skin damage, MASD, is a huge one.
Right, MAS.
Think of MASD as the main category. Underneath that, you have specific types like IAD from urine or stool.
Incontinence-associated dermatitis.
Correct. And ITD, intertriginous dermatitis, from sweat trapped in skin folds. Plus, peristomal dermatitis around stomas, periwound dermatitis from wound drainage, even MARSI, medical adhesive-related skin injury, often has an irritant component.
Wow, okay.
Even just prolonged contact with, say, an occlusive dressing that traps moisture or bandages or even plastic that can cause irritation. And heavy wound exudate itself can be irritating, sometimes signaling infection too.
So if you suspect irritant dermatitis, what's job number one?
Find the cause and get rid of it. That's paramount. Remove the irritant, and usually the rash clears up in, say, 2 to 4 weeks.
And how do we help it heal and stop it coming back?
Barrier products are key. Things that create a protective film, liquid acrylates, petrolatum, zinc oxide creams or pastes. Sometimes using window dressings can help shield the skin too.
Okay.
And of course, managing the underlying cause is crucial, like using stool hardeners for diarrhea, finding ways to reduce excessive sweating, and always using gentle skincare practices.
That leads us nicely into MASD, moisture-associated skin damage. You called it a type of irritant dermatitis. Why is it such a big deal in clinical practice?
Because it's essentially skin inflammation and erosion caused by being exposed to moisture for too long. And that moisture urine, stool, sweat, wound drainage, stoma output often contains irritants. It's super common because so many patients have conditions that lead to this prolonged moisture exposure.
Right.
And like we said, it is a type of contact irritant dermatitis. It's the big umbrella term for IAD, ITD, peristomal, periwound damage. Actually, the WHO recently put bodily fluid-related skin issues under contact irritant dermatitis in the ICD-11 classification.
That's interesting. And you stressed making sure we don't confuse MASD with pressure injuries. Why is that distinction so vital?
Because the causes are totally different, which means the prevention and treatment strategies have to be different too. Pressure injuries come from pressure and sheer cutting off blood flow.
Okay.
MASD is primarily from that chemical and physical irritation from moisture. Your source material actually has a table 13:1, that compares how they look, especially in the perineal area. Getting the diagnosis right is step one for effective care. You don't want to treat one like the other.
Makes sense. So who is more likely to develop MASD? Are there sort of internal patient factors or external things we should watch out for?
Definitely. There are intrinsic factors, things about the patient themselves, and extrinsic or external factors.
Like what?
Intrinsically, think excessive sweating, maybe a higher skin metabolism making the skin warmer, abnormal skin pH, a history of sensitive skin or atopy.
Okay.
Also, deep skin folds where moisture gets trapped, thinning skin from aging, and maybe lower sebum production, which weakens that natural skin barrier.
And the external factors?
Those are things like chemical irritants in products, biological irritants in stool or urine, mechanical stress from friction.
Right. Rubbing.
Exactly. Fungal growth like Candida loves moist areas, high humidity environments, incontinence itself, obviously, and even using the wrong hygiene practices like scrubbing too hard can all make MASD more likely or worse.
Okay, let's zoom in on IAD, incontinence-associated dermatitis. This must be a daily challenge for so many clinicians. What's the core concept here?
The core thing to remember is that IAD is specifically the irritant dermatitis from prolonged skin contact with urine and/or liquid stool. It used to be called diaper dermatitis across the board.
Right.
But IED is a better term for adults. The key takeaway, it's this complex mix of chemical and physical irritation working together to break down the skin's defenses.
Can you elaborate on those chemical and physical parts? What's actually happening to the skin?
Chemically, urine and stool shift the skin's naturally slightly acidic pH towards alkaline. This messes up the stratum corneum, that outer protective layer. It gets overhydrated. The lipid structure changes, it becomes more permeable, so irritants get in easier and the barrier weakens. The alkaline pH also activates fecal enzymes, which are very irritating, and less bacteria grow more easily.
And the physical side?
Well, wet skin is just weaker. and can't tolerate friction as well. So even normal movement, clothes, absorbent products, or cleansing can cause damage. And ironically, cleaning too much or too aggressively can strip natural oils, making it worse.
Wow.
And crucially, we now know IAD is a big risk factor for developing pressure injuries. They often go hand in hand.
That's a really important link. You mentioned a study on alkaline urine. What did that find?
Yes, that study showed that even just repeated exposure to alkaline urine caused visible irritation in healthy people. It suggests the skin just doesn't get a chance to recover its acidic pH and repair itself with constant exposure.
Right.
And they also found something key. Wet skin has a much higher coefficient of friction. It's stickier, basically, so it's much more easily damaged by rubbing or shear forces during care.
That makes sense. And just how common is IAD? Do we see it a lot?
Unfortunately, yes. That big Gray and Giuliano study looked at adults in acute care in the U.S. They found almost half, about 47%, had some form of incontinence.
Wow.
And of those incontinent patients, nearly half again, or about 21% of the total study group, had IAD. The slightly better news was most cases were mild or moderate.
Okay.
They also highlighted that fungal rashes, usually candida, were pretty common in people with IAD, showing up in maybe 15% to 32% of cases, depending on the study.
So if we catch IAD early, can we usually reverse it?
Yes, that's the general understanding. It's typically reversible, especially with the right care. It usually starts as just redness in the perineal area, but it can progress to partial thickness skin loss if the irritation continues.
But usually not full thickness.
Generally not, unless other factors are involved. There are assessment tools to grade severity, but some are a bit complicated for everyday use.
Is there a simpler way to categorize it for practical use? The outline mentioned a 2015 system.
Yes, exactly. An expert panel came up with a simpler three-category system back then. Category 0 is basically intact skin, no redness, in someone who's incontinent.
Okay.
Category 1 is mild redness, maybe some swelling, but the skin's still intact. Category 2 is moderate to severe redness, plus other changes like small blisters, erosion, skin loss, or even signs of infection.
That seems more manageable.
And that evolved into the Ghent Global IAD Categorization Tool, GL/A. It basically has two main levels. Category 1 is persistent redness, Category 2 is skin loss, and then each is subdivided into A for no signs of infection and B for signs of infection present. It helps guide treatment a bit more specifically.
Got it. So moving to prevention, which is obviously key, what are the core strategies to stop IAD before it starts?
The absolute main goal is to keep skin contact with urine and feces to a minimum, both in duration and amount.
How do we do that?
It's a multi-pronged approach. First, promote continence if possible. Second, use the right absorbent products effectively. Third, use best practices for skin cleansing. And fourth, really think about the skin's microclimate, that local moisture and pH environment, and choose products and practices that support a healthy skin barrier.
Let's break those down. Promoting continence, what does that involve practically?
Well, first, look for reversible causes, maybe a UTI, weak pelvic floor muscles that could respond to exercises.
Right.
Then there are non-invasive behavioral things, bladder or bowel training schedules, managing fluids and diet, encouraging mobility. And in some specific cases, like severe prolapse, surgery might be an option.
And absorbent products, what's best practice there?
Modern products are much better now. They use superabsorbent polymers to lock away a lot of moisture, keeping the skin drier.
Okay.
Many are designed to maintain a slightly acidic pH next to the skin, which is healthier. Breathability is also key. Some briefs use special fibers to help with that. But the most critical part, changing them frequently, especially immediately after a bowel movement.
What about catheters or fecal pouches? Do they play a role in prevention?
They can divert urine and stool, yes. But the evidence comparing them directly to good absorbent product use for preventing IAD isn't super strong. And they come with their own risks, discomfort, infection risk is significant, potential for device-related pressure injuries, and maybe even worsening incontinence long term. So they're usually reserved for exceptional cases, severe IAD maybe, and only temporarily.
Okay, that makes sense. Now, skin cleansing. You hinted that soap and water might not be the best approach anymore.
You got it. Traditional alkaline soaps strip the skin's acid mantle, raise the pH, make the barrier weaker, and can encourage bad bacteria. Even just water, with prolonged exposure, overhydrates and weakens the outer layer.
So what should we use instead?
Best practice now leans towards cleansers with a slightly acidic pH, closer to the skin's natural 4.5 to 5.5. Use soft materials, gentle cleansing. Pat dry. Thoroughly remember, wet skin is prone to friction damage.
Right.
Good alternatives are things like bath oils, fragrance-free. no-rinse liquid cleansers, or pre-moistened wipes designed for perineal care. The no-rinse options avoid water and often dry quickly, minimizing friction risk.
Interesting.
Many of these newer cleansers use non-ionic surfactants, things like PEGs, alkyl polyglucosides, polysorbates. They're generally much less irritating than the harsh surfactants in old-school soaps because they don't strip away all the natural oils.
Okay, so after cleansing, what's the next step for protecting that skin barrier?
Since we often can't completely avoid all contact with irritants in incontinent patients, applying leave-on products is really key. These should ideally protect and moisturize.
Protect how?
Protectants form a physical barrier. Think petrolatum, zinc oxide, dimethicone, or acrylate copolymers. They shield the skin from moisture and irritants. Just be aware, petrolatum and zinc oxide can sometimes affect how well the incontinence pad absorbs.
Okay, and moisturizing.
Moisturizers help replenish the skin barrier components. They often contain humectants like amino acids, lactic acid, glycerin, urea, which attract water to the skin. But maybe avoid these on already soggy, macerated skin.
Right.
They also have emollients like plant oils or petrolatum to soften the skin, and other goodies like ceramides, fatty acids, vitamins. Many products combine both protecting and moisturizing actions. Some are even built into cleansing wipes for a simple 1- or 2-step process.
So what if IED has already developed? How does treatment differ from prevention?
The basic principles are the same: minimize contact, protect the barrier. But the focus shifts to actively healing the damaged skin, reducing inflammation, and dealing with any secondary infections.
Okay.
Leave-on barriers can still help with mild Category 1 IAD. But for Category 2, where the skin is broken, you need to be more careful. Sometimes, for open areas, a drying lotion might be better than a thick, greasy barrier cream.
And if it's not getting better?
That's a key point. If you don't see improvement in 3 to 5 days, or if you suspect infection, definitely get a specialist consult. Topical steroids might be prescribed short-term for severe inflammation, but not routinely because of side effects like skin thinning.
What about those secondary infections? What are we usually dealing with?
Candida yeast is the most common culprit, often coming from the gut. But bacteria like E. coli, Staph aureus, Pseudomonas can also move in.
So what do we do?
It's really important to get a swab or sample before starting antimicrobials so you know what you're treating. And we need to be careful with antimicrobial use generally to avoid resistance.
Right.
If you need dressings for severe IAD, use atraumatic ones. Silicone adhesives are good to avoid more damage. Remember, wet skin, friction, and trapped urine stool under dressings is bad news, so use them temporarily and change frequently.
Is there an easy way to remember the steps?
There's a helpful mnemonic, ACT, assess, cleanse, treat. Keeps the key steps in mind.
Nice. It sounds like putting all this together really works. The outline mentions studies showing positive results.
Absolutely. Lots of research shows that consistent, evidence-based IAD prevention protocols significantly cut down prevalence rates, especially in hospitals, nursing homes, even in kids.
What do those successful protocols have in common?
Key things are avoiding harsh soaps, using pH-neutral cleansers, not scrubbing, using moisturizers and protectants regularly. Also, managing incontinence episodes, promptly scheduled toileting, using containment devices appropriately if needed.
Okay.
And when using absorbent products, making sure they wick moisture away well, and maybe choosing ones with that slightly acidic surface pH. So, structured skincare, no-rinse cleanser, gentle application, humectants, emollients, barrier products is the way to go. And of course, add an antifungal if you diagnose a fungal infection.
Okay, let's switch gears slightly to ITD, intertriginous dermatitis. This happens in skin folds, right? What's the main cause?
Exactly. ITD is skin damage from trapped sweat and friction between skin surfaces and folds. Unlike IAD, we don't have great data on how common it is and no formal risk assessment tools yet.
Where do we typically see ITD?
You need to look anywhere skin folds exist and can trap moisture. Common spots are under the breasts, in the armpits, the groin, and in abdominal or pubic skin rolls, especially in heavier individuals.
And who's most at risk?
People who are overweight or obese are definitely at higher risk because they have more and deeper folds. Women with large breasts, folks with limited neck mobility creating neck folds, even babies with their natural chubby folds.
What happens when moisture gets trapped in those folds?
Well, it creates this warm, damp environment that's perfect for microbes to grow. The skin pH there also tends to become more alkaline, encouraging bacteria and fungi.
Like what kind of organisms?
Cultures often show things like Staph aureus, strep, Pseudomonas, Proteus, Enterococci, even VRE, and very commonly Candida.
So careful assessment of all scaffolds is really important then. What are we looking for specifically?
You have to be a systematic check under breasts, abdomen, groin, behind knees, elbows, neck, back, even between the toes. It often starts as mild redness, usually mirroring itself on both sides of the fold.
A mirror image, okay.
Then it can progress to more inflammation, maceration, that soggy white look, erosions, oozing, crusting. Patients often complain of itching, pain, and sometimes a distinct kind of musty odor.
How do we prevent ITD?
Prevention is all about hygiene, keeping those folds clean and crucially dry. Use pH-neutral cleansers, avoid harsh scrubbing or friction, and pat the areas completely dry.
And if ITD develops anyway, how do we manage it?
Keep up the gentle cleansing and drying, making sure the folds stay dry is paramount. Sometimes using absorbent materials helps, special moisture-wicking fabrics or even soft cotton cloths tucked into the folds.
Okay.
Depending on the severity and if there's infection, topical steroids might be used for inflammation, and definitely topical antifungals if candida is suspected or confirmed.
Right. Moving on to skin tears. These seem to be getting more attention lately. What exactly is a skin tear, according to the experts?
Yes, the International Skin Tear Advisory Panel, ISTAP, gives us the standard definition. It's a traumatic wound from mechanical forces, and that includes removing sticky adhesives. It varies in depth, but doesn't go down into the subcutaneous fat layer.
Who gets them most often?
People at the extremes of age, the very young and the elderly, and those who are chronically or acutely ill are at highest risk.
And why the increased focus? Are they more than just minor cuts?
They definitely are, especially with aging and chronic illness. Even these seemingly small wounds can take a long time to heal. Patients often report significant pain, and like any chronic wound, they can really impact quality of life.
So understanding risk and prevention is key.
Absolutely. Healthcare professionals need to recognize who's at risk, prevent them whenever possible, and know how to manage them properly when they happen. Prevention is always the goal, but good management minimizes suffering. Historically, they were kind of dismissed as minor, so research lagged behind, but that's changing now.
You mentioned ISTAP again. What has their role been?
ISTAP is this international group of wound care experts who formed specifically because there was such a gap in knowledge about skin tears. They've been crucial in developing consensus statements on everything from epidemiology and causes to assessment, prevention, treatment, and documentation.
Okay.
And, importantly, they developed and validated a practical classification system and a toolkit to help set up skin tear prevention programs.
Let's talk about that classification system. How does it categorize skin tears?
First, ISAP defines a skin flap. That's the piece of epidermis and maybe dermis that gets pulled away accidentally by shear, friction, or blunt force, not a surgical flap.
Got it.
The system has three types. Type 1, no skin loss. It's a linear tear or a flap tear where you can put the flap back down, completely cover the wound bed.
Okay.
Type 2, partial flap loss. The flap that's left isn't big enough to cover the whole wound bed when you reposition it.
Right.
Type 3, total flap loss. The entire wound bed is exposed, the flap is gone.
That seems clear. What about how common they are? Are they really as prevalent as some people think?
They are definitely seen often, especially in the elderly and critically ill. The true numbers might be underreported, particularly outside of hospitals. Some researchers think skin tear rates could be similar to pressure injury rates in some groups.
Really?
Yeah, studies in long-term care show a huge range, maybe 4% up to 26% prevalence. So yes, they are a major issue there, possibly as big a burden as pressure injuries.
What usually causes them? What are the big risk factors?
Often, the exact moment isn't known. But common culprits are things like bumping into wheelchairs or furniture, trauma during transfers, falls.
Makes sense.
Interestingly, they seem to happen more during busy times in facilities. In older adults, environmental hazards are often involved. Key risk factors identified are impaired activity, mobility, sensation, or cognition.
Okay.
Also, being dependent for daily activities, sensory loss, using assistive devices. Patients needing total care are at highest risk, often getting tears during care. But surprisingly, independent walkers are second highest, usually getting tears on their legs. Other causes mentioned are equipment injuries, dressing removal trauma, even patient agitation. Things needing more study include age, gender, polypharmacy, edema, nutrition, pressure injury risk, dry skin, cirrhosis.
Interesting point about sun exposure, too?
Yes, there's a hypothesis that long-term sun damage makes skin on the arms and legs more fragile with age, which fits with where most tears occur. Cultural differences in sun exposure might even explain some prevalence variations.
And the crucial point about not mixing them up with pressure injuries.
Absolutely critical. A skin tear on the buttocks can look like a stage 2 pressure injury, but the cause is different. Trauma versus pressure. They must be documented accurately as skin tears. ISAP actually has a risk assessment pathway and program to help identify and manage risk.
It sounds like a lot contributes. Let's unpack some of those general health risks.
Sure. Problems with senses vision, hearing common in aging or critical illness, increase fall risk, which is a major cause of skin tears. Cognitive impairment in the elderly, kids, ill patients can mean less cooperation with prevention, maybe more agitation leading to trauma. Nutrition is huge too. Malnutrition or dehydration makes skin weaker, more prone to tearing. So assessing intake, hydration, weight is vital.
And polypharmacy, taking lots of meds.
Yes, common in older adults. It can lead to drug interactions, confusion, dizziness causing falls, and some specific drugs like corticosteroids directly affect skin health, making it thinner and slowing repair.
What about mobility-related risks?
We touched on this: wheelchair use, falls, transfer difficulties, blunt trauma are all major factors. Needing help with daily living activities puts people at high risk, especially those totally dependent.
And the ambulatory ones get them on their legs?
Yes, often on the lower legs. A history of falls or being high risk for falls is a big red flag. And then there's just the mechanical trauma combined with intrinsic skin changes. Aging makes skin thinner, drier, less resilient. Neonates also have incredibly fragile skin. Critical illness itself causes skin changes that increase vulnerability.
So given all these risks, what are the essential prevention strategies?
It has to be a multifaceted approach.
Yeah.
Proper positioning, turning, lifting, transferring techniques are fundamental to reduce stress on the skin.
Okay.
Protecting vulnerable skin, long sleeves, padding equipment, using non-stick dressings that come off gently. Skin sealants or liquid bandages, soft silicone dressings can add a protective layer.
What about tape?
Avoid harsh tapes if possible. Use stockinettes or soft wraps instead. Support dangling limbs with pillows. Minimize harsh soaps and alcohol. Use gentle no-rinse cleansers. Pat dry, don't rub. Moisturize regularly, especially for dry skin.
And the environment.
Keep it well lit. Reduce clutter to prevent falls.
Fair.
And crucially, educate all staff on gentle handling and skincare. Studies show these kinds of protocols using specific cleansers, staff training, especially for dementia care or RN education, really do reduce skin tear rates.
It's good to see how the classification has improved, too, making it more practical.
Definitely. The early systems had limitations. The STAR system was complex. ISTAP is much more user-friendly, widely accepted and translated, making it a global standard now. And patient education is part of it, too, letting them know they might be prone, especially over bruised areas.
So when a skin tear does happen, what's the immediate management plan?
Okay, step by step. Assess the injury. Control any bleeding with gentle pressure. Cleanse the wound, usually with saline. Gently remove any dead tissue or debris if needed.
What about the flap?
If there's a flap, carefully try to realign it over the wound bed. Then classify it using ISTAP type 1, 2, or 3. Measure it, document everything. Address the cause if you know it.
You know what?
Prevent more trauma, prevent infection. Manage pain. Control exudate with the right dressing. Start moist wound therapy with a non-adherent dressing to protect the tissue. Oh, and a really important practice point. Check tetanus status. If there's a break in the skin and no booster in 10 years, consider TIG, especially before any debridement.
Got it. Okay, let's shift to psoriasis. A chronic inflammatory condition, but you said it's more than just skin deep.
Absolutely. Psoriasis is a chronic, non-contagious autoimmune disease. Affects maybe 1–3% in Europe and the US. We don't know the exact cause, but genetics play a big role. It speeds up skin cell growth and causes inflammation. But yes, it's now seen as a systemic inflammatory disease with important links to other health problems.
How do you usually diagnose psoriasis? What signs point to it?
Diagnosis is mostly clinical, based on history, family history, and a good physical exam looking at skin, scalp, nails, joints. Sometimes a biopsy helps confirm or rule out other things, looking for skin thickening, called acanthosis.
Are there any specific signs to look for?
Two classic ones can help. Auspitz's sign. If you gently scrape off a scale, you see tiny pinpoint bleeding points. That's because the epidermis is thin over dilated capillaries.
Okay.
And Koebner's phenomenon. New psoriasis lesions appearing at sites of minor skin injury, a scratch, a bug bite, even a surgical scar.
Interesting. You mentioned systemic links and comorbidities. What should wound specialists be aware of?
Big ones include metabolic syndrome, that cluster of obesity, high blood pressure, high blood sugar triglycerides, low good cholesterol. Nail changes are very common. Pinning thickening, often mistaken for fungus.
Right.
And psoriatic arthritis inflammation in joints, often fingers and toes, sometimes causing a whole digit to swell up like a sausage, called dactylitis.
Any others?
Yes, links to depression, alcoholism, obesity, insulin resistance, hypertension, heart attack, Crohn's disease, COPD, fatty liver disease, coronary artery disease. Quite a list. So, wound specialists need a broad awareness and know when to refer complex cases to dermatology.
What are the common ways psoriasis presents on the skin?
The most common is chronic plaque psoriasis. You see these well-defined, raised red patches with silvery white scales, typically on elbows, knees, lower back, scalp, between the buttocks. Severity is often measured with a PSI score looking at redness, thickness, scaling, and area affected. Then there's intertriginous psoriasis in skin folds, groin, armpits, under breasts. Here the scale might be minimal or gone because of moisture. Looks like shiny red patches. Important to check for secondary infection there.
Any other forms?
Pustular psoriasis is less common. It features sterile pustules, little pus bumps, often very itchy, can be localized, palm soles, or widespread. Might see other lesion types too. Management depends on severity and other health issues. A key point for wound care. The skin around a wound in a psoriasis patient is vulnerable because of Koepner's phenomenon. Maceration or skin stripping can trigger new lesions. Using liquid barrier films can help protect that peri-wound skin.
And how is psoriasis generally treated?
Treatment depends on the type and how severe it is. Mild to moderate cases often respond to topical steroids, non-steroidal agents, maybe steroid injections into plaques or UV light therapy. For severe disease, systemic drugs, traditional ones, or newer biologics are usually needed.
Okay, our next challenge, Epidermolysis bullosa, EB. This sounds incredibly difficult. It's genetic, causing very fragile skin.
Yes, EB is actually a group of rare genetic conditions. The hallmark is extremely fragile skin and mucous membranes. Minor friction or trauma causes blistering and erosions. It could affect internal organs, too, in severe forms, inherited either dominantly or recessively. There are 4 main subgroups based on where in the skin layers the blistering happens, over 20 variants in total.
Can you briefly describe the main subgroups?
Sure. EB simplex. Blistering is within the epidermis, the top layer, usually the most superficial, often mildest, triggered by heat friction. Junctional EB blistering occurs in the lamina lucida, part of the basement membrane zone connecting epidermis to dermis. Often severe from birth, affects skin and mucosa. Sadly, some infants don't survive.
Oh dear.
Dystrophic EB blistering is deeper, below the basement membrane in the upper dermis. Can range from mild to very severe. Causes major complications like finger-toe fusion, malnutrition from mouth-esophagus issues, risk of infection, heart problems, and a very high risk of aggressive skin cancer, squamous cell carcinoma, if they survive into adulthood, especially the recessive form.
That's devastating.
And the fourth is Kindler syndrome, a rare mixed type. There's also an acquired form, EB acquisita, not inherited, looks a bit like another blistering disease, bullous pemphigoid, a critical point. Always watch for skin cancers in dystrophic and junctional EB patients.
Given this fragility, how on earth do you manage wounds? Treatment must be very specialized.
It is. The core is extremely gentle wound care, adapting wound bed prep principles. Gentle cleansing, managing infection and inflammation, controlling exudate, protecting those fragile edges. Pain and itch are also huge issues to manage.
Is there a cure?
Correcting the gene defect is the ultimate goal, but gene therapy is still future hope. Bone marrow transplant has been tried, but results were disappointing due to rejection drugs, infection risks, and the fragility of the cells themselves. We also have to manage cofactors like anemia, often need transfusions, and nutrition.
Nutrition must be hard with mouth blisters.
Very difficult. Oral and esophageal blisters make eating painful, leading to malnutrition and deficiencies. A dietitian is crucial. Realistic goal for hemoglobin in severe chronic wounds might be around 80 GDL. Patient concerns like itch are managed with antihistamines. Pain needs a multi-pronged approach, acetaminophen, sometimes narcotics, gabapentin and pregabalin for nerve pain and itch. Mobility can be tough with hand-foot deformities, so ADL assistance is often needed.
What about the actual wound care techniques? What's different?
There are best practice guidelines. Think maintenance care, minimal trauma. Avoid sticky tapes, use silicone adhesives if needed. Gentle cleansing with compresses saline, dilute acetic acid, maybe mild antiseptics like chlorhexidine for mouth or PHMB. Dilute bleach baths, sometimes used for antimicrobial effect.
What about blisters?
Lance new blisters with a sterile needle to drain, but leave the roof on as a natural dressing. Topical antibiotics, maybe silver sulfadiazine. Use carefully on open infected blisters. Monitor silver levels if used long-term or widespread. Debridement must be very conservative, atraumatic.
How do you diagnose infection?
Look for 3+ NURGE criteria: non-healing, exudate, red friable tissue, debris, smell. Treat with topical antimicrobials, silver dressings, iodine, etc. Non-adherent foam dressings are good for exudate. Superabsorbent pads if needed, but heavy exudate might signal deeper infection. Check Stonia's criteria. Systemic antibiotics, often liquid oral form, or IV for resistant bugs.
Maintaining moisture balance sounds tricky.
It is. Foams are often good. Maybe hydrogels carefully for dry wounds, absorptive dressings for wet ones to avoid maceration. Things like growth factors haven't shown much benefit. Surgery needs durable flaps grafts. Holistic care is key advocacy. Support groups like DEBRA International. Patient comfort is paramount. Let them try dressings. Measure wounds regularly if trying new things. Biopsy any suspicious areas for early cancer detection. SCC can be very aggressive, sometimes needing amputation and recessive dystrophic EB. Be a facilitator. Support self-management. It's complex, multi-system, incurable, needs a whole team.
Okay, finally, let's touch on these concepts. Skin failure, terminal ulcers, scale, skin changes at life's end. You said there's some controversy here.
Yes, significant debate. Some believe these are distinct entities. Others attribute the changes to known factors like pressure or ischemia. The evidence base, especially for skin failure and terminal ulcers, is limited. Mostly expert opinion, case reports, not large studies. There's a bit more on terminal ulcers and the Scale Delphi consensus statements. Table 13-9 in your source summarizes them.
Let's start with skin failure. What's the idea behind that?
It came from observations back in the late 80s, early 90s, that when multiple organs were failing terminally, the skin seemed to break down too easily. Like the skin itself was failing along with other organs due to poor blood flow, hypoperfusion.
Is there a clear definition?
Not really a universally accepted one. Langmo proposed one in 2006. Skin death due to hypoperfusion alongside other organ failure. She suggested acute critical illness, chronic ongoing disease, and end-stage types. But there are no tests to confirm these stages. A 2015 study identified some predictors in the ICU, like PAD, prolonged ventilation, liver respiratory failure, sepsis, cautioning against calling it all pressure injury. But yeah, it needs more work on definition and criteria.
And terminal ulcers, like the Kennedy terminal ulcer.
Right. The KTU is the classic example, that butterfly-shaped lesion on the sacrum seen in dying patients, first described by Kennedy in '89. The mechanism isn't clear, and evidence is limited. Some later studies describe similar pear or butterfly-shaped purple-maroon pelvic injuries, sometimes with skin striations appearing very close to death, which researchers felt weren't typical pressure injuries. CMS does recognize terminal ulcers, though some clinicians remain skeptical.
And stale skin changes at life's end.
This came from key opinion leaders agreeing in 2008 that skin can break down at the end of life due to internal physiological changes and external factors, and that not all breakdown is preventable or due to poor care.
Okay.
A Delphi process followed to validate 10 statements about these end-of-life skin changes, not primarily caused by pressure, classic skin failure, or neglect. There hasn't been much new research published on scale itself since those original documents. The one Swedish study looked at pressure injury predictors at end of life, so still an evolving area.
This has been incredibly thorough. Let's try to ground it with those patient scenarios from the chapter.
Good idea. First one, 74-year-old woman hospitalized, COPD, urinary incontinence. Developed redness in the perineal area from urine clear IED.
What did they do?
Started an IED protocol. Gentle cleansing with a one-step cloth, zinc oxide barrier cream, plus standard pressure injury prevention support surface, turning, encouraging movement. And Figure 1317 shows significant improvement after just 6 days compared to the start. Figure 1316 shows protocols work.
Definitely. What about the second case? Sounds more complex.
Yes, 75-year-old man, lots of issues, cardiac, COPD, renal disease, pacemaker, warfarin, edema, bumped his swollen foot with his walker. Developed pain, discoloration, swelling, Figure 1318.
Ouch.
Surgery initially suggested amputation, but he refused. So conservative management, elevation, povidone iodine on a blister that formed, letting blood dissipate, mobilization. Figure 1319 shows his foot after 2 months looking much better.
But there was more to his story.
Yes. On admission assessment, they found numerous skin tears and bruises on his back, thought to be from being dragged in the ED, Figure 1320. And a large, full-thickness type 3 skin tear on his arm, Figure 1321. Back tears were type 2 and 3.
So what did they do for the tears?
Prevention first, arm protectors, Figure 1322, proper transfer techniques, local care, saline cleanse, soft, non-adherent silicone dressings, moisturizers for his generally fragile, bruised skin. They had some leakage from the arm dressing, so they just increased change frequency, Figure 1323.
Did they heal?
Yes, the back tears healed in about 2 weeks, figure 1324. He went to rehab with no knee tears. The arm tear healed completely after about 6 weeks, figure 1325. And his foot resolved too, discharged home intact. Really shows how complex cases can be involving multiple issues simultaneously.
Those scenarios really bring it home. The chapter also has those show what you know questions, which are great for review.
They are. And for anyone wanting to dig even deeper, the full reference list starts on page 686 of the source text.
This has been a fantastic, really comprehensive deep dive. To wrap up, what were the main areas we hit today?
We really tried to clarify the differences in dermatitis allergic versus irritant. We navigated the whole world of MASD, especially IAD and ITD, looking at prevention and management. We stressed recognizing and managing skin tears using the ISTAB system. We touched on the specifics of psoriasis and the very challenging condition of EB. And we introduced those complex end-of-life skin concepts.
What's the main message you want people to take away?
Just that understanding these conditions, which are common but can be complex, is so fundamental to good patient care across many settings. We really hope you'll think about the risk factors we discussed and remember those core principles of prevention and evidence-based management.
And maybe a final thought for you, the listener. Consider how interconnected skin health is with a person's overall health and well-being. Knowing more about these challenging conditions doesn't just improve physical care, it really impacts patient comfort and quality of life, especially for our most vulnerable patients. Thanks for joining us on this deep dive.